Well, thank you all for coming. It's a pleasure to be here. It's sort of like a homecoming for me. It's been 2 years since I left Methodist, and it's always a pleasure to be part of Re-Evolution. I used to help Mahesh put this program together and help him with all the logistics, and it's amazing to see how much this program has grown and become really one of the premier programs for cardiac surgery, immune-invasive approaches, especially the hands-on components that you'll have an opportunity to work with and be able to get your hands to apply some of the things that the speakers will be talking about. So I'll introduce a mentor and then our former chairman here at Methodist DeBakey Heart and Vascular Center, Dr. Alan Lumsden, who will be speaking about imaging in the operating room, a new paradigm and an opportunity. Alan is a vascular surgeon, and they have really taken the imaging aspect to a whole new level as an integral part of the practice, and we have a lot to learn from them as cardiac surgeons. Thanks, Alan.
Thank you much. And again, just let me add my welcome to Houston, and thanks for all the industry support. So I always say, what's the first, second, and third most important things when you're buying a house? It says location, location, location. And in the kind of world that we're moving into, what are the most important tools that we're going to have? Imaging, imaging, imaging. And if you look at some of the specialties that have done really well, orthopedics controlled the imaging, urology have controlled the imaging, cardiology have done a great job basically controlling the imaging. And we as a group of surgeons have often defaulted out of that. That's a big mistake. And I think that's the thrust of what you're going to hear this morning is the importance of understanding the imaging, because that's the platform that you're going to use a lot of the tools. So when I'm standing doing a case, basically I always say to the resident, what's the most important piece of equipment in this room? They always say, you, sir. And I said, that's right. Yeah, you're right. What's the second most important piece of equipment? It's that imaging system that we're using and building into these operating rooms. So this is actually a talk that I gave at STS. It's one that I'm about to give the Oshner lecture on Saturday morning, and it's the same idea. This is the next evolution, possibly revolution in the cardiovascular world. So let me show some of the conflicts. I'm going to talk a little bit about Siemens, because this is, they're the guys who provide these imaging platforms that we utilize, and this is a huge deal that's just been done here. Really emphasizing the focus of the Heart and Vascular Center is that tower that's been built next door, and down below us is some of the most advanced imaging equipment will go in here in the next 2 to 3 months that exists anywhere basically in the world, and we're very excited about that. So let me take you back to my evolution. So a lot of surgeons want to be trained, ED, past tense, they don't want to train. They want to basically be given it, it's going to be easy, and you go, all right, I can do that. So let me tell you a little bit about my personal journey. I trained at Emory University. This was my mentor, Bob Smith. I was trained in open vascular surgery. The most sophisticated catheter that we passed at that time basically was a Fogarty catheter. Fogarty is a heart surgeon, okay? If heart surgeons have been absolutely instrumental in the development of this, then we tend to actually give it all away. So Tom Fogarty was a heart surgeon who developed this idea of a Fogarty catheter. He developed it when he was a medical student. He was a medical student who was helping a surgeon trying to pull clot out of an iliac artery, and they put long forceps up blindly, no imaging, pull the clot out, and he said, I think I can do it better than that. He cut the tip off a surgical glove, put a rubber band around basically the end of a long tube, and put a syringe on the end and said, hey, sir, do you think this would work? The IRB basically approved it. I think that was him. And he went ahead and basically that was the evolution of really what was the first endovascular device, and at that time, not associated with imaging. I submit to you that this is the single most effective way of moving clot that exists to this day. But the main issue for us was we didn't train in endovascular procedures or imaging, and yet all of a sudden along came stent grafts. And stent grafts, and this analogy between stent grafts and percutaneous valves is so profound for cardiac surgery that there are many lessons basically which can be learned from there. Other thing, and it's important to look at other guys' toolkit. This is an example basically of looking at other guys' toolkit. We were instrumentally involved in the development of endoscopic vein harvest. This happened to be unfortunately a patient of mine. You can see that the vein has been harvested. We've clearly undercut the posterior flap and it died. And looking at watching one of our plastic surgeons, they were using a thing called the Snowden pencil retractor, and they were doing latissimus dorsi flaps. I went to a guy called Monty Eves, he's still at Emory, and said, think you could use this thing to take vein out? He was an assistant professor, I was an assistant professor. The next day, he happened to be doing a minimally invasive latissimus dorsi harvest at the VA. I had a fem pop to do, just need a little short piece of vein. and said to him, hey, you want to try it? He said, yeah. We approached the IRB, that was us. We said, yeah, and we did the first endoscopic vein harvest. That then led basically to us work, that's Monty, he was a plastic surgeon who was doing this. And so we fundamentally believe that a lot of solutions lie in somebody else's toolkit, and I think the imaging is going to be an important part to that. That actually led basically to the issues of this patents. This is, Emory uses this as an example of how two guys working together and working with industry can actually bring things to fruition. It ain't the best endoscopic vein harvest system, but it still basically put my kids through school, frankly, from this. But back to the stent graft. So what happened was that most of us went into vascular surgery because we like doing abdominal aortic aneurysm surgery. And then along comes a guy. Guy's called name is Juan Parodi. He was a vascular surgeon who worked in a relatively small center down in Buenos Aires. And he took a Palmaz stent. Palmaz stent's another crazy guy. He was a radiologist in San Antonio. He said, I can take a piece of chicken wire, I can put it on a balloon, I can blow some chicken wire up inside a blood vessel, and that thing is going to be called a stent. You'd be very well off today if you'd been involved in the development of those patents, because nobody believed, including me, that this thing was going to work. Well, Juan Parodi said, well, let me take a piece of Dacron. Dacron came from here. DeBakey basically got Dacron from Foley's department store downtown. Because he was looking for Dacron? No, because what he was looking for, they had sold out of, and the shopkeeper said, hey, try this stuff. This is called Dacron to this day. It's still the main thing used to replace open aortas. And so what Parodi did was he took the Palmaz stent, and he took a piece of Dacron, and he sewed them together, and he basically developed a delivery system. And that was developed for patients who were prohibitive risk for open surgery. Never stays prohibitive risk. These things all start high risk, prove the efficacy, and move. And I'm sure basically this resonates strongly basically with what's going on in the valve world at the moment. And this essentially spawned an entire industry in the development of endografts, led to approval. And so we're faced in surgery with this idea. This is actually a title that I stole from the president of the Society of Interventional Radiology, but one for us: revolution, evolution, or extinction. Nobody owes you a living, and we basically got to be able to reinvent ourselves basically and move with the time. I love this one because this is, I'm Scottish, as you can probably tell. Here's Mel Gibson showing, he's William Wallace here. The middle guy happens to be Charles Darwin. What you don't know is that he went to Edinburgh University Medical School, which is what I hear from. And then the third thing that's of relevance to Scotland is basically the Roman Empire. The Romans, I presented at Hazem Safi's grand rounds. He said, when I heard you were a vascular surgeon coming to Houston, thought you were out of your mind. There were no vascular surgeons. The word was cardiovascular here. And he said, but, Hazem is a student of history, and he looked at the Roman Empire. They came out through Rome, up through Central Europe, Eastern Europe, Western Europe, reached the English Channel, built ships, sailed across the English Channel, swept up through England. And then if you notice that little area way up at the top up here, right here, that green area, that's where Scotland was. They built two walls from one side of the country to the other to keep the damn Scots out of the Roman Empire, because they never could keep those guys down. So follow the Scots, basically, whatever they got. So this is how we started at Emory. Okay, this was Imaging 101 at that time. Here, all of a sudden, basically, we're in a situation, and now that Dr. Kleiman, the cardiologist, is here, I've got to moderate. I've got to be a lot more temperate at what I'm going to say about the role of surgeons, basically, in this. Now, you're right, Neil, never. And so we had no idea how to do this. And so we knew nothing about imaging. And I will say that this C-arm was the enabling technology in the vascular surgery world, in the cardiac surgery world, for the first time ever. Remember, we would do completion angiograms on a femdistal bypass, a flat plate, just a chest X-ray. It wasn't even digital at that point in time. Put it under the leg, you'd inject dye and say, shoot. They'd pull the flat plate out from underneath, they'd run down to the X-ray department to develop it, and come back 15 minutes later and go, missed. You have to do it all over again. Because we couldn't see things real time. So all of a sudden, basically, this idea of digital imaging came along with vascular packages. Now, all of a sudden, you're starting to put high-quality imaging, into the environment. And we had to do this with the radiologists because we really had no idea what to do about it. The table is actually an orthopedic spine table. Supported both ends. We could move the imaging system top to bottom. And the original endograph, called Ancure, was probably the most sophisticated endovascular device ever invented, being implanted by the most inexperienced people ever invented, deploying with some of the worst imaging. And so despite that, we actually managed to get through it. But without that, without the fact that our core operation was being threatened, I'm not sure we would have ever evolved into doing this. You are at that stage at the moment. And I think it's very important that you gravitate to using these. And this is one of my partners, Tom Dodson. So not everybody in the vascular surgery world even thought we should be buying, a portable C-arm. And Tom's going, no, we're surgeons, Alan. How many times have you heard this? We don't need to be doing this stuff. Really? Well, I submit to you that the most competent vascular interventionalist is a surgeon who knows the benefits of some open and can do the endovascular and makes that right decision. And in the absence of that you are an inferior being in terms basically of cardiovascular interventions. You should have brought some cards, you could give abuse. So along comes Perotti and he invents this. And look at the bottom bullet. This is John Bergen. He said, in vascular surgery, no change for the better has ever occurred, that wise and good men have not opposed. Don't listen to your mentors. You need to understand, the direction that the technology is going to be moving, and getting involved basically in the imaging is extraordinarily important. Another cardiac surgeon who massively influenced this was Ted Dietrich. Ted Dietrich started the Arizona Heart Institute. He is a heart surgeon. He's a heart surgeon who was here. And how Ted went from being in Methodist Hospital, Houston, Texas, where I say your gender identity was based on the size of the incision that you made, and the idea basically of making small incisions, your gender identity was strongly questioned around here. And so how he went from that environment to setting up the Arizona Heart Institute, which was really focused on endovascular interventions, is staggering. But here's the reason. The reason is when you go back and look at, for example, translumbar aortography, we're now trying to relearn 30 years later for treating endoleaks, some of the first cases were actually done here. And at that time, the thoracoabdominals were being done up in the operating room. Between cases that run up basically to a fluoro system, they had a whole bunch of flat plates and kind of a sausage roll type thing that you could kind of pull them through. You'd stick a needle in the back until you got blood return, and then somebody at the bottom would go, shoot, and you'd pull these things through, and then you'd develop them and go, yeah, okay. That's where one of the places that direct puncture was developed. And so Ted basically saw the benefits of that, moved forward, and when he left here, the Arizona Heart Institute was entirely focused on the development and education we see of endovascular procedures, and that's really how this started. So again, I think it's one of the messages I think you get, and this is what I said at ISMIX, was that we often think of an endovascular procedure as being two components. There is a delivery system, and there is the core therapeutic part that the patient benefits from. So when Neil puts a stent inside basically the LAD, the only thing the patient benefits from is blowing up that stent. Everything else is delivery system. When you do basically a coronary bypass, really the thing that the patient benefits from is the Lima to LAD bypass. Now I should have had the poll question. What is the most therapeutically efficacious, the stent that Neil puts in the LAD or that Lima to LAD bypass? I may force you to answer that question. Now let's look at the delivery system. Who's got the more acceptable delivery system? So what has happened over the years is that surgeons have refined the therapy and believe that that will carry the day in the delivery system. That is a big mistake. And the mistake that we have all made is not evolving the delivery system and maintaining that core therapeutic part. We have given up on the efficacy part of this for the sake of a delivery system. That's really what a conference like this is all about, is to try and say, how do we still deliver what has been tested over 30, 40, 50 years, but change the delivery system, because the standard delivery systems are unacceptable. So when I came down here, really, there's really hardly anybody doing endografts. And this is Dr. DeBakey, this is the original vascular surgery group, and he was still practicing. He'd call one day and he said, Alan, what are you doing? And the answer was always, whatever you want me to do, sir, I'll be right up. And he shows me an x-ray and said, there's kind of chip-chop descending thoracic aneurysm. And he said, can you put a stent graft in this? Wasn't entirely sure what the right answer was supposed to be, but said, yes, sir, I believe we could do that. And he said, we developed that operation here. I said, yes, sir, I'm aware of that. And then he said, but there are lots of complications of that. I think if you can do this with the stent graft, you should go ahead and do it. But call me, because I need to call the referring doctor. 95, still hustling for cases. You got to admire that. But I think it kind of shows you the kind of people that you wanted, the visionary people basically who see over the horizon about, you know, how we can't basically stand on our laurels because the cheese has moved. And I think this is a great little story. Anybody know about who moved the cheese? Little story, make it simple, is a maze. And every day, basically, 4 little mice get put in the maze, and they run through it, and they find the cheese in the top right-hand corner. And so they get faster and faster about finding the cheese, and they get big, and they get fat, and they get happy. And then one day, somebody moves the cheese from the top right-hand corner to the bottom left-hand corner. The DeBakey mouse would be in there going, well, the cheese has always been here. Cheese has moved. Let me go find the cheese. I'm out of here. And he goes to find the cheese, and he does fine. Most of us will hang out for a few days saying, hey, life's been pretty good with the cheese in the top right-hand corner. I'm going to keep coming back here. Cheese is going to come back. But then you get kind of hungry because you realize the cheese ain't there. And they move off, and they do fine too. But that last mouse, he realizes the cheese has been great, and I've been really, really good here. And I know the cheese is coming back, and he doesn't do quite as well. So we don't need to be the first guy, but we can't be the last guy. And so we've moved essentially, the cheese has moved from this really to modern day hybrid operating rooms. The hybrid operating rooms, Neil, you got to cover your ears up here, Chapin. I was hoping to get through this before Neil got here. Hybrid operating rooms, cardiology, urology, orthopedics have learned to control the imaging. The imaging is the key really to be able to perform these advanced interventions, and understanding this and interacting with it is extremely important. You're going to hear about wires and catheters and all this kind of stuff you'll be interested in. You must understand the image, and this is the platform for everything that you're going to basically be doing in the future. You don't, as fellows, go to an institution that will not give you a hybrid operating room. You're used to basically in the situation where Dr. Ramchandani says, I want a new Omni retractor. And the administration goes, ooh, it's pretty expensive. Dude, that's $5,000, Dr. Ramchandani. This is fairly tight times in medicine. Well, the radiologist and the cardiologist will go, I want 5 new cath labs, 2 MRIs, 3 CT scans. Oh, absolutely. And it's just an education process for the administration because they're not used to surgeons making these kind of demands. You must have access to this, for the future. And for fellows, somebody's in here is recruiting you and they're not going to give you access to this. Don't go there, because once you get there, it's a hell of a lot more difficult to get this stuff than negotiating basically when you're up front. And this is where you're going to be working upstairs. The C-arm was actually developed off car assembly lines basically in Germany. This is called the KUKA robot. There's robots basically. This, you'll get a chance to see this. This has got an MRI in the background. This is being built in that tower next door and will be up and running for clinical operation, hopefully really within the year. So, understanding the image. And so in the past, this is dynamic MR. And one of the powers of the Heart Center here is that all of this is being done by our colleagues. It's all part of the Heart and Vascular Center, MR, CT, echo, nuclear, everything. And so the opportunity to work with people like Deepan Shah, who's a cardiologist from Duke who's interested, allowed us to start acquiring things like this. This, believe it or not, is probably 8 or 9 years old, this picture. And every time I show it, people go, oh my gosh, you must have some sort of special MRI scanner. No, we don't. It's exactly the same scanner you can buy. But we got the people who actually know how to do this and can ask the right questions. And so this is a huge field. It is anatomical. Need an anatomist to interpret it. There's no radiation basically associated with this, and we can see the motion of a septum. And in the past, this was something that you looked on the screen. We can now import this and fuse this, and that's kind of where I'm going to go with this. We'll develop some of because it's not just a picture on a screen anymore. It is used to directly intervene on these patients. And this is the candy cane view, and you can see these little black and white streaks that are over here. Black and white on an MR is like blue and red on an ultrasound or an echo. It is bidirectional flow. And the resolution of this is now down to the point you can actually, those are evulsed intercostal arteries. So what you see is people going, oh, well, let me see where the fenestrations are. There are dozens of fenestrations. And the idea that you seal off an entry point and the whole thing thromboses is ludicrous. And understanding how we're going to treat these is going to be dependent on understanding the relative contribution of these numerous fenestrations to the flow pattern in the false lumen. And Mike Reardon is the national PI basically on the ascending stent graft trial. And this is kind of an example of how the type A dissection comes in here rapidly, can now be evaluated with a dynamic CT. These images are then imported, and we'll kind of walk you through as I finish roughly how to do this. We can actually put those landmarks up so that we don't even need to inject dye at the time that we're doing this, or minimal dye to actually position the stent graft. So let me move you and give you a little primer on cone beam CT and image fusion. You will live in the world of image fusion for your professional careers. A CT, a regular multi-slice CT scan, spins around the patient. That's what it looks like basically on the left. And you get that full gantry rotation very rapidly. Well, these are coming into the operating room, but right now most of these CT scans I know are acquired using what's called cone beam. The cone is the radiation cone coming out of the radiation source, and you move that around the patient. So this is important. Cone beam CT is acquired in an angio system. All the vendors try to confuse you. Philips basically calls it expert CT. Siemens calls it Dyna CT. It's all the same thing. Just call it cone beam CT. It's not specific to a vendor. They can all do it. But it is the next enabling technology. And this is kind of how we do this in the operating room. You've got to basically control your LAX about the patient. You've got to be sterile above and below the field, and the whole system moves around the patient. And there's some certain side advantages to this. We have the most limber anesthesiologists here on the planet. This is Jan. She's one of the CRNAs, and she's learned a limbo dance basically around this thing. If they're sleeping over there, you just move it over and dunk them on the head a couple of times. They're not going to sleep after that. So there's some real challenges with having these moving parts basically in an operating room. And I'm not going to have time to walk you through all of this stuff, but the premises are this is a DICOM data set. DICOM is basically software for imaging. It is portable. We can look at it up on the floor. We can look at it in the operating room. We can import it and overlay it on top of the patient there, and it allows us to intervene on that, and then we can work with it. And I'm going to kind of walk you through that. These are some of the new hybrid rooms, basically. This one actually exists over at MD Anderson. This is how you bring a real CAT scanner, and we'll have this pretty soon. A real CAT scanner into the hybrid operating room. This will revolutionize trauma. And so this is not just a cardiovascular thing. I think this will transform surgery because it'll allow you to do a lot of image-guided, needle-guided procedures that are otherwise fairly challenging. What's absurd in trauma management is to take a sick patient, run them basically from the ER to the CT scanner, decide they need an angio, take them to the angio suite, then they need an operation and bring them back. That's all going to be done in one place. And the opportunity for surgeons is you will control this in your environment, and it will change the way that trauma is going to be managed. So let me talk a little bit about fusion images and give you a little primer on this. So here's a Mrs. Smith. Mrs. Smith is lying on our operating room table when we've created a cone beam CT. We didn't give her any dye, so all we can really see is the bones and spine. You see it pretty easily because it's just X-ray. Now here's Mrs. Smith, had a multi-slice CT scanner. It was done in the office 2 weeks ago. We did give her dye at that point in time. So on Mrs. Smith, you can actually see her blood vessels. We can see her bones, we can see her blood vessels, but we don't care about the blood vessels quite yet. So what we do is we take the multi-slice CT scan from the office 2 weeks ago, import it into the workstation, do this cone beam that gives me this picture on the left. You can see all the bones. And then we basically bring those things together, these data sets, digitally on the workstation, fuse the bones. It's called bone-to-bone fusion. This is how you align it. Then we can put the blood vessels back in, and then we get rid of the bones. And the blood vessels at this point are all now overlaid on top of Mrs. Smith, lying on the table. Same thing for the valves. And so we can now see these blood vessels and we can work on them. And so we figured out what do we need to put an endograph. We need to know where the renals are, we need to know where the SMA is, and we draw little circles on them on a computer. And then basically when we x-ray Mrs. Smith, what we're going to see is on the right. It shows the bifurcation, shows you all the important landmarks, shows you the right and left corneas, shows you where the annulus is, basically shows you where the innominate is. All of that stuff has been done, and Mrs. Smith ain't got any more dye basically superimposed on top of it. So that is essentially what this does. And the way that it really works is you take the multi-slice CT scan, we essentially do a cone beam CT, which gives us a much smaller volume. That's the advantage of having a real CAT scanner. We can fuse everything in the patient. And then we essentially, you acquire that, you reconstruct the CT scan, the images get pushed back onto this 3D workstation, then you can actually draw these targeting. You define what's important for you to do the procedure, and you draw these targets basically up there. My timer's not working up here. Oh, see, there we go. I'll move this to the right. And that is essentially how you push this back onto the workstation and you target things off this. You can take this to another level. This is the way we do it, actually. It's very advanced, is that The advantage you've got is that all of our patients have bones in their blood vessels called wall calcification. We believe that wall calcifications are a unique digital signature for you. We're going to give this to the CIA, and that we can, that nobody has the same wall calcification pattern. And that if we fuse based upon wall calcifications, we don't really care about the bones, we don't care about the spine, we care about the ascending aorta. And if we take those wall calcifications or the valve annulus pattern and we fuse those together, you get highly accurate calcifications. So when you see two colors like this, it means two different CT data sets that are essentially being fused together. And that allows us to be very accurate really in what we're doing. This is essentially what it looks like, and the importance basically of developing this in the operating room. So I've touched some fairly advanced concepts here, but these are fundamentally, the rules of this game are you need to have access to high quality imaging. The predicate of that is you need to know something about it. Okay, this is not just walk in, stick your foot on the fluoro pedal, or you will be undervaluing what you can do and the tools that you can use to develop this. All of the developments in the future will be based upon integrating imaging into the workflow of what you're doing, in these operating rooms. And I think we as a group of cardiovascular surgeons basically have a big opportunity to play a role in that. And, partnering with others, I will say I'm willing to steal knowledge from anybody, even Neil. But working with other people, they bring a skill set that you learn from them. Our neuroradiologists we work with regularly. I probably learn more from them than anybody that I work with. I don't learn from working with other vascular surgeons. I learn from working with people from different specialties who come with a different skill set and a different set of knowledge. So I submit to you that I think imaging is important. I'm going to wind it up at that, and now you're going to start hearing about the tools that you need above and beyond imaging. Thank you very much indeed for your attention.